Hello, welcome to our mini-series of bite-sized sessions covering some of the more common issues encountered when working with older people. Each session is structured around a clinical question, and our aim is to help you approach the issue thinking a bit more like a geriatrician. The best part is they're all around 10 minutes. I'm Ian Wilkinson, I'm a geriatrician in Surrey, and joining me remotely are...
I'm Jo Preston, I'm a geriatrician in South West London.
I'm Alice O'Connor and I'm a teaching fellow in East Surrey.
And this session is about those patients who are anemic, but you're not quite sure why.
So Mr. Sang has a haemoglobin of 70 and my consultant has asked me to get a cross-match and do a medical review. Help.
This might be a slight exaggeration, but it's not far off what some junior doctors get asked to do when they're looking after older adults on non-medical wards. But before picking up the phone, here are 5 things that it would be handy to know in advance.
Thing number 1 is the anemia acute or chronic? If they're available, have a look at the previous blood test to get an idea of the haemoglobin trend over time. Has it dropped slowly or quickly? Was it low before, but it's now even lower? Thing number 2, if it's acute, is there any evidence of active bleeding that we know of? Remember that this might also include large internal collections of blood, such as a hemothorax or a large hematoma. Number 3, are there any other abnormalities in the full blood count? It's always a good idea to look at the results for yourself rather than relying on a verbal or a written handover of a single value from someone else.
Number 4, is the person symptomatic? So common symptoms include breathlessness, fatigue and feeling lightheaded. Symptoms can guide decisions about whether or not to give a blood transfusion or an iron infusion and how quickly you need to correct it. And finally, although it sounds obvious, number 5, has their anemia been investigated previously? We know that lots of older adults will be anemic despite investigation and not have a sinister cause found. So you don't necessarily want to go re-investigating people. So look back at their previous blood results. If they've got any recent clinic letters, any other investigations they've had and how recently, you might already have the answer there in front of you. Or they might have just ruled out a couple of differentials to give you a starting point from there. You might need to get a collateral from family or GP to help you with that.
So this is a flowchart that I drew, which shows one way of channeling your thought process to rule in or out some of the more common causes of anemia. It's by no means an exhaustive list, but feel free to use it if you find it helpful. So one of the most important acute causes to rule out early is an upper GI bleed. With this, you classically see a corresponding rise in urea, depending on the size of the bleed. And this can sometimes be difficult to spot in patients who have an AKI as well. And it's important to know what their baseline urea is. And if somebody's haemoglobin has dropped acutely within the first 24 to 48 hours of admission to hospital, and there's nothing to suggest that they're bleeding, and it's worth checking if they've been given a large volume of fluid, as this can cause a dilutional drop in haemoglobin. If this is the case, you'll usually see a proportionate drop in their hematocrit, and these patients will usually have a chronic anemia that was being masked by hemoconcentration due to dehydration. However, it's always important to rule out bleeding in anyone with an acute drop in haemoglobin.
If the anemia has been present for some time, one of the first things I go to look at is the MCV. So in patients with a low MCV, so a microcytic anemia, the most common cause is iron deficiency. Anemia of chronic disease can also cause a microcytosis, but the MCV is more likely to be normal. Chronic kidney disease and chronic inflammatory conditions are typical causes of this sort of anemia of chronic disease. A large or a high MCV, a macrocytic anemia, is less common, and there are lots of different causes, but bear in mind excess alcohol intake and vitamin B12 and folate deficiencies. Bear in mind that people may have a mixed picture, so an anemia of multiple causes, which might make the MCV less reliable, and that is one of the situations when an RDW is useful to give you an idea of the spread or the distribution of the size of the cells.
So if you suspect that someone has an iron deficiency anemia, you will want to have a look at their iron levels. Transferrin saturation is the easiest to interpret. If it's low, then it usually indicates an iron deficiency. Ferritin is often used to evaluate iron stores, but just remember it's an acute phase reactant protein as well. So if someone has a concomitant infection or inflammation around, the ferritin will rise and you might be falsely reassured.
And as we mentioned earlier, it's also good to look for other abnormalities in the full blood count. A blood film will sometimes be requested automatically or by the lab team if particular abnormalities in cell size or shape are picked up. You can also request one yourself, but may need to discuss it with a haematologist or a biomedical scientist first.
The other tests on this slide are more for the investigation of a macrocytic anemia, but it's often a good idea to check B12, folate, thyroid function and liver function tests in older people if they've not been done recently anyway. Lactate dehydrogenase, LDH, is a marker of tissue damage and can be elevated for many reasons, but we usually check if we're concerned about hemolysis or lymphoma. If you suspect a myeloma, you'll need to request a serum and a urine electrophoresis, but we're not going to talk about myeloma in any great detail today.
So we've got this far without talking about taking a thorough history, which is obviously the most important thing. But it's really, really helpful in identifying the underlying cause of someone's iron deficiency anemia. So especially if someone's got symptoms that suggest that they might have underlying bleeding or a cancer as a cause of their iron deficiency anemia, remember to ask about all sites of bleeding, so not just the bowels. Ask about vaginal bleeding in women, hematuria in men, and people may not be so forthcoming with that information if you don't ask them about it directly.
And you should try and get an idea of what their diet is like. Perhaps ask them to describe their typical food in a day. The foods pictured on the slide are all good sources of iron, so oily fish, green vegetables, red meat, certain grains and nuts. And there are loads of patient leaflets available online which have dietary advice to suit lots of different dietary requirements. And vitamin C intake is also important because without that, the iron won't be absorbed properly. And don't forget to ask about alcohol, as we mentioned before. Dependent drinkers can develop macrocytic anemia due to poor nutrition, but also due to the toxic effect of alcohol on the bone marrow.
On examination, you may notice signs of the anemia itself, such as a pallor or a flow murmur, but really you're trying to get further information about what might be causing the anemia. Key things to look for are signs of cancer, so weight loss, masses or enlarged lymph nodes, and any more specific signs such as jaundice in hemolysis or peripheral neuropathy in a B12 deficiency. And don't forget to examine for breast lumps as well.
So blood transfusion will sometimes be necessary. For example, if someone is actively bleeding and their hemoglobin is going down quite quickly. However, transfusion does carry its own risks and so should be avoided where possible. There are some good studies showing that restrictive or conservative transfusion policies actually can improve outcomes, but not if someone's acutely bleeding. So we're talking more about in the chronic stage. In that circumstance, iron infusions are being increasingly used to treat the underlying iron deficiency that's causing the anemia. That's both in hospital inpatients as well as outpatients in day units. They're quite good because they avoid the GI side effects of iron tablets. They're effective for longer than a blood transfusion, and they are very good at replacing the iron stores where they may not be so well absorbed with tablets. So iron infusion might be appropriate for people who are symptomatic, and if they've got hemoglobin which is sort of sitting around 70 or 80, as long as they're hemodynamically stable and their symptoms haven't started acutely.
And B12 and folate replacement can be started by anyone, and the dosing's pretty straightforward. You can just look in the BNF to find out how to start them off. With folate replacement, it's worth making sure that B12 is replete first, otherwise there is a potential for exacerbating neurological complications of B12 deficiency. And if the underlying cause is not immediately clear, then further investigation will be needed before the anemia can be treated. But in the case of endoscopy, this may provide the treatment too, for example, if a bleeding point is identified.
Before pursuing any path of investigation, it's important to consider what your goals are and whether or not these match up with your patient wishes and wants. Pragmatism and shared decision-making are very important, particularly for people who have multiple interacting, conflicting health problems. From a medical point of view, consider whether or not the investigation can be safely and successfully carried out, and if so, whether any potential diagnoses can equally be safely and successfully treated. If treatment's not going to be a viable option, consider whether making a diagnosis is going to be helpful in other ways, for example, to guide advanced care planning.
When speaking to patients, you want to try and provide them with as much information as you can and as they need to be able to make an informed decision. Find out what sorts of tests and treatments they'd be willing to undergo in order to get a diagnosis, and whether a diagnosis in itself is important to them to have. Remember that their priorities might differ quite significantly from yours, from their family members, from other members of the MDT. So it's really important that we understand what they want and that their voice is at the centre of the decision-making process and further investigation.
In the notes below, we've included a link to our website, which is www.thehearingaidpodcasts.org.uk, where you can find a full 40-minute podcast episode on pragmatic investigation. There are also a couple of useful resources in the notes below for providing patients with information about dietary iron. The MDTea podcast and learning resources are free to use, and they all cover a wide range of topics concerning older people, so anything from sarcopenia to sex.
You can also check out the rest of this mini-series for some more bite-sized learning. And we hope this episode of Help has been a help. Bye-bye.
Bye.
Bye.